Welcome, everybody. Very, very special occasion today for two reasons. One, we have our beloved Mariana in the co-discussant seat, and I don't need to introduce the concept of what's happening on Fridays anymore. I think I've said it often enough. The idea being that Prof. Res has many, many things going on, and we have to try to find people who to fill his shoes. And the people who are more than ready and able are essentially the CP Solvers legends, and one of them is Mariana, who has been part of the team for many, many days, weeks, months, and years. Um, and I was just reflecting on the fact that I think Mariana's been involved in every single aspect of what we do, from the teaching point recaps to VMR leadership, to social media, and then more recently, a super secret effort that you'll all hear about very, very soon. Maybe not very soon, but soon. So no better way than to honor you, Mariana, and have you jump into Rez's very massive shoes, which I'm sure you will fill. I'll hand the mic to you to say hello, and then we'll introduce everybody else.
Hello, everyone. I'm Mariana. I'm always very, very pleased with the kind words from Rabih. I'm very happy to be here. I may feel a little rusty because it's been a while since my last discussion, but I'm very, very excited.
Thrilled to have you, my friend. This would not be possible without two people who are staffing the fort, and today Lyra is scribing. I don't feel like Lyra needs to introduce herself anymore to you all, but formalities are formalities. So Lyra, why don't I hand the mic and maybe update us on how your celebrations were yesterday?
Yeah, hi everyone. My name is Lyra. I'm a medical student from Russia. What Rabbi was talking about, it was my cat's birthday yesterday, so we celebrated it pretty well. He ate some treats. Yeah,
Nice.
I was
Awesome. I'm
happy.
so glad to hear that. He's happy, which is all that matters. Another person who doesn't need intros is Vinny, who's doing teaching points today. Vinny, I'll hand the mic to you to just update people on what's new in your life.
So, hey everybody, I'm happy to be here again doing teaching points. It's been a while. So let's rock it.
You're gonna have a lot of work to do, my friend, because we're in for a treat. Our third treat, probably more delicious than Chester's treats, even though Lyra might completely disagree. We have Jeffrey back, rheumatologist extraordinaire. And the off chance, Jeffrey, that folks may have not have heard your previous two cases, do you mind telling them a little bit about yourself, and then we can jump into your case?
Hey, I'm Jeffrey. I'm one of the Duke rheumatology attendings. I've been interested in clinical reasoning since I was in undergrad. It's one of the things that drew me into medicine, and really excited to be here today and be able to share with you guys this case. If it's okay with you guys, are you going to start?
Yeah, let's do it. Let's rock and roll.
All right. So I have a 42-year-old woman who is presenting to the hospital. I'm just going to give you a little bit of background. She has a history of ANCA vasculitis on rituximab. And she's presenting to the hospital because of pains and numbness and tingling, kind of diffusely, but mostly in her hands and feet. So a little bit more about this history. She says that usually with every period, and she has a history of heavy periods, she will get a feeling of her bone grinding. That's how she describes it, as her arthritis. And this usually occurs in her hands, feet, and knees, and usually lasts a few days. That comes on with on one of her periods. But now these arthritis pains are becoming more persistent, and they're no longer related to just the start of her periods, but she's still having them even without the periods. With regards to the numbness tingling, she says that she's never had this sensation before, but over the past 3 weeks, this new numbness and tingling that also occurs in her hands and feet. Initially, it was so intermittent, like just lasting for a couple of seconds, she thought it was nothing. But now it's persistent, and she feels like she has trouble feeling the bottom of her feet. And she has had one fall, and she's afraid to keep walking. Otherwise, on review systems, she denies fever, cough, shortness of breath, chest pain, rash, eye problems, other muscle weaknesses, and foot drop.
Oh my gosh. Mariana, well, this is quite the case to come back to. This will stretch both you and I, but we're going to be stretched together. Um, I think it's difficult already, Mariana, because we know this patient has a very rare and serious condition, ankylosing vasculitis on rituximab. And maybe before we even talk about what's happening now, it's probably helpful just to put out what we know about this condition. So, I mean, what would you say if you were describing it to your medical student next year who's going to be working alongside you? If they asked you, hey, can you just tell me a little bit about ANCA vasculitis? What would your description be to that student?
Yes. So I would say that vasculitis, I would start with vasculitis in general, and we
Mm,
need to know that vasculitis is an inflammation in the vessels.
yeah.
And depending on the type of vasculitis, we may have inflammation of small, medium, or large vessels. And if I'm not wrong, vasculitis is inflammation of small vessels. Is that correct?
Yes.
So I would start with that. So because of the ANCA vasculitis and the small vessel inflammation, we can have like impairment in the kidneys or in the skin or um, I'm not sure if you're gonna have lung
Mhm.
impairment with ANCA vasculitis, so I would do a review about that. But something that always comes to my mind when we have like a very important past medical history like that, I'm always considering if the new condition is associated with this primary diagnosis or if it is a complication of the medication we are using for these diagnoses or if it's something else that is not related to that. So I think it's very important to do like a review of the main diagnosis and then try to associate the new symptoms with that in one of these three ways, disease, medication, or new condition.
Absolutely superb. I think that was an outstanding start. And I think ultimately, as you said, ANCA vasculitis is an autoimmune condition as a small vessel vasculitis. And I think the difficulty that rheumatologists, who are probably the sharpest diagnosticians, have is all their diagnoses are working diagnoses, really. You can prove somebody has cancer. You can prove somebody has an infection. It's very, very hard to prove that somebody has an autoimmune disease. And ultimately, the thing that proves that somebody has an autoimmune disease is actually that they have a sustained remission with immunosuppression, and that when you suppress their immune system, they get better. And so, unfortunately, whenever somebody's course with a history of autoimmune disease deviates from that pathway, the first thing that rheumatologists tend to do is ask themselves, how strongly was the case for this original diagnosis in the first place? Because if you learn that this patient was diagnosed with ANCA-associated vasculitis 2 days ago, um, and was given rituximab and how it has this symptom complex, you would certainly cast doubt on that diagnosis. Even more, if you learn that, like Lyra, this patient has a cat and the cat licked her and she has Bartonella risk factors, then you would be even more suspicious that this diagnosis is invalid, right? So I think you're absolutely right. The problem with the fact that we are dealing with an autoimmune landscape is immediately when somebody develops a new complication, as you said, we have to question the validity of the underlying diagnosis. And so that opens up a whole slew of issues, let alone even if the diagnosis is valid, whether it is flaring, whether it itself is flaring, or whether the medication is doing something, be it causing an infection, be it causing another autoimmune disease. So drug-induced lupus is a great example of how a medication causes another autoimmune disease, or whether the medication is suppressing the immune system to the extent that now cancer can grow and develop because there's no immune system to curtail it. So I'm right there with you. I think for now, we should call this a working diagnosis of ANCA-associated vasculitis and review what the degree of confidence was around that diagnosis. And then in parallel, even if we believe the diagnosis, to entertain the possibility of infection from immunosuppression, autoimmunity either as a flare of the vasculitis or a drug-induced autoimmune condition, or cancer from immunosuppression. And so all that is at play. We don't think about any of that if the patient comes in and says, oh, well, the reason I'm here is because I have a little cut on my finger from the kitchen knife. All of this is irrelevant, right? We say, okay, let me clean it for you, give you your tetanus, and send you home. So even though we worry so much about these patients, we have to worry about them at the right time, depending on what they're presenting with. So that's why the HPI and analyzing the HPI is so crucial. So that is probably the longest way to ask you, what do you think about the HPI? What happened there?
So the patient started with pain in both hands and feet and knees. So with this, we have a picture of arthralgia that we have to deep and to think about, but also patient has numbness and tingling. So I would say that this is arthralgia associated with some sort of neuropathy. And because it seems like it's distal, I would say that it's distal neuropathy. And for me, it seems like it's asymmetric, so it's bilateral. So I would frame this picture as arthralgia associated with bilateral distal neuropathy. And from that, I would think how we can make progress associating this to chief complaint. Rabih, you're muted.
Oh, can you hear me now?
Yes.
Yeah, great observation, Mariana. I think I think you should spend much more time with your family. Your clinical reasoning is incredibly sharp. This patient, it's interesting to reflect with you that this patient's thorax and abdomen seem to be spared. And I'm always very happy as an ER doctor when somebody says I have problems in my limbs and don't have any problems here, because the truth is morbidity and mortality are often with problems in the thorax and abdomen. And so when somebody has a complaint in their extremity, I usually relax. But the times where that's not true is a patient has a complaint in every single extremity. Because most of the time, the patients I see, they have some neuropathy in maybe one or two limbs, or some arthritis in one or two limbs. But if every single limb is affected, hands and feet, that's a problem. And it's very tempting to say, oh, okay, I'm just going to localize the lesion to the part of the extremity, and that'll help me a lot. And here, I'm struggling with that just like you are, because she has features of nerve disease with the numbness and tingling, but also features of osteoarticular involvement with the arthritis that she's describing. And so that's already confusing, let alone the fact that every single limb is involved. And so immediately what happens when both the structure, i.e. nerve or joint, that is involved is in question, and the fact that the patient has all four limbs involved, I ask myself, wait, am I really sure there's no internal organ involvement in the chest or abdomen? No systemic fingerprint to this disease? Because it's so much easier in the spinal cord, which courses through the chest and abdomen and radiates out into the peripheral extremities, than it is to have every single extremity be numb. It's also way more common to have problems, for example, in the blood vessels centrally, like the aorta or the subclavian, that radiate out peripherally. So all this is not actually helpful in the moment, but it's to share with you the following observation. It's often great when patients have a problem in their limbs in terms of morbidity and mortality. That's because we worry more about the chest and abdomen. But this does not apply to this patient for two reasons. Every single limb is involved, and the specific structure that's dysfunctional in her limb, nerve or bone or joint, is also in question. So that pushes me to discard my assumption that the core of the patient's body, chest, abdomen, spine, everything in there is spared. And I would first try to make sure that there isn't a clue that something more central is happening to this person, be it in her spinal cord or in her blood vessels, and then try to move on to the periphery. So we're in a very tricky situation, Mariana, because the medical history is very, very tricky, and the HPI is very tricky. So we're going to have to be very, very careful with how we steer this patient. All right, Jeffrey, mic to you.
All right, that was incredible. I love listening to your pearls. I mean, I feel like these are the real secrets that you don't get taught in med school residency. You can only learn from kind of doing it on the job. So next aliquot is going to be about her histories and her medications. So past medical history 5 years ago. So before 5 years ago, essentially she was healthy, no medical problems. 5 years ago, had COVID. Fortunately, had pulmonary embolism from that. And then 2 years ago, she developed ANCA vasculitis. It presented with diffuse alveolar hemorrhage and renal failure. There was a renal biopsy, and that showed crescentic post-immune glomerulonephritis consistent with ANCA vasculitis. She also had p-ANCA and MPO checked at the time, which were both positive, and was started on high-dose steroids and rituximab as a standard therapy for ANCA vasculitis. She also has a history of GERD and abnormal uterine bleeding. And notably, I guess I could have included this in the first aliquot, but she's actually so she was an outpatient, but she's starting to get fevers, and she's been using NSAIDs around the clock for her pain. And so when her labs checked, they saw an AKI, and so she basically gets admitted for AKI and fever. As far as the medications that she's taking, so she is on rituximab, as well as pentamidine for PJP prophylaxis. For her previous PE, she's on Eliquis. She's been taking Tylenol and ibuprofen, and she's been taking oral medroxyprogesterone for abnormal uterine bleeding, and she takes famotidine for GERD. And then I'm just going to round it out with brief surgical, family, and social history. So surgical history only notable for tubal ligation. Family history only has diabetes type 2, no autoimmune diseases or cancer. And social history, she's originally from Mexico 25 years ago, but hasn't been back in the last like 5-10 years. She works as a stay-at-home mom. There's no recent travel history or unusual exposures. She's monogamous with her husband. As far as her habits, she denies tobacco and drug use, but she was previously an alcoholic and quit in 2019.
Oh my God, Jeffrey, I'm so intrigued. So Mariana, what do you think? Do you think that the diagnosis of ANCA vasculitis is a strong one, a medium one, or a questionable one? What do you think?
I would say that because of the renal biopsy and also because the alveolar hemorrhage that this patient had, this is a very strong diagnosis. I wouldn't be questioning this at this point. And especially because this patient now has a fever, I am very concerned about a flare of the disease.
Yeah, I agree with you. It's a classic presentation of ANCA-associated vasculitis, especially microscopic polyangiitis, with the idea being that the patient has crescentic glomerulonephritis, diffuse alveolar hemorrhage, and positive serologies. And so I think everything lines up for this to be an accurate diagnosis. Yeah, so I think that's what we can establish about that. How did now so the fever made you think, oh, could this person have a flare? What do you think your journey to that diagnosis will be like? What do you think your evaluation will entail?
So I would start with like regular labs. I would be evaluating the kidney with the creatinine. For I like looking for something that shows that there is an acute process going on. What else? I don't think like the serology is helpful in acute process like that because we already have the diagnosis. Maybe another chest CT just to see if there's an acute process going on.
Yeah, I think in terms of diagnosing flares of autoimmune disease, I think that the natural arc that the journey takes is you have to exclude mimickers first. That's because even if your autoimmune disease is flaring, it's hard to rule out a concomitant infection or even a cancer. And so I think our focus will be initially on whether she has an infection or a malignancy or a drug-induced complication. Our focus will be on that, but her flare may be so bad that sometimes while we make sure she doesn't have an infection, we simultaneously immunosuppress her. So hypothetically, if she has really severe glomerulonephritis now, and her creatinine has gone back to 10 with a, a picture compatible with glomerulonephritis. Sometimes we empirically immunosuppress because the flare is so strong, but we at the same time work up other possibilities. So that's definitely real. But ultimately, I think the conversation that you brought up is the idea that there are very few instances in rheumatology where you can prove that somebody's having a flare. And the thing that is often tempting is to say, let's recheck the serologies. And if the serologies are, quote, worse, then the patient must be having a flare. And that is almost always an untrue statement. How untrue it is depends on the disease. So in a patient who has lupus nephritis, for example, the presence of a increasing titer of double-stranded DNA and hypocomplementemia is a very strong argument that their lupus is flaring, but it's not bulletproof. And so the question is, of the serologies that we have here, the ANCA and the MPO, are they valuable in diagnosing the flare? And of course, Jeffrey can correct me if I'm wrong, but I think the big picture internist answer is not so much. And in general, trending RF, CCP, ANCA, MPO, many of the room serologies, very not at all productive. But maybe Jeffrey, if you have a moment, I'm curious what your take on that is.
Yeah, you're completely right. The serologies are only helpful for diagnosis in the most patients. Really, the only time where serologies help with flares is in lupus in certain individuals with lupus nephritis. But for almost every other autoimmune disease, it is not helpful, only for diagnosis.
Thank you so much, Jeffrey. Yeah, so you have a lot of work to do, Mariana. And I think it's interesting now because if we go back to what you said, is this a joint or nerve problem? It's very unusual for joint and nerve problems to feature a fever. So now we have a febrile, neuropathic, and osteoarticular process. And so what causes that is a very small number of things. I'm most curious to see what this person's exam looks like. Is she just reporting numbness and tingling because her arthritis is really bad and that's annoying her? Or does she have no arthritis at all? So I think we have a complicated background. We have inflammation, but I think honestly, the best clue is to figure out how is this inflammation showing up? And it's showing up in a weird way, aches and pains in her bones and nerves. I think that'll be the most helpful thing to study, not the serologies, not anything else. So I'm really curious to see what she looks like on exam and what else Jeffrey has in store for us.
All right. So the next title class is going to be the exam. So vital signs noted for a temperature of 101.4, blood pressure is 128/72, heart rate is 98. She is satting 94% on room air, and she's got a regular respiratory rate of 20. In general, she's not in any acute distress. She doesn't have any on HENT exam, no sinus tenderness on palpation, no palpable cervical or submandibular lymphadenopathy, and normal appearing conjunctivi. There's no signs of ocular inflammation. On cardiovascular exam, she's regular rate and rhythm, has got 2+ peripheral pulses. There's no extra sounds on auscultation. On pulmonary exam, she does have intermittent expiratory wheezing that occurs even when she was talking, and otherwise has some bilateral fine crackles that are best heard at the bases. Abdominal exam is soft and non-tender. Dermatologic exam shows no rash. On her musculoskeletal exam, she has actually no synovitis and full range of motion of all her joints, but she does have some mild tenderness of palpation to her wrists and ankles. Those were the only joints that bothered her on the exam. There was no effusion or warmth, though, when palpating. And then neurologically, she had normal cranial nerves, 2 through 12. From our peripheral neurological exam, she had some decreased sensation over the dorsum of her left thumb, decreased sensation from the right hand, from the tip to the wrist, decreased sensation from left foot to ankle, and also decreased sensation from right foot to up to the mid shin. Otherwise, her motor exam was completely normal, including all the upper and lower extremity, and as well as neck and shoulder kind of proximal muscles, as well as abdominal muscles. So normal motor exam, she had normal reflexes, negative Babinski, and normal proprioception testing.
Oh, Jeffrey, this is an unbelievable exam. I feel like a neurologist is doing this. So really, really nice job with that neuro exam. Yeah, so Mariana, what's jumped out to you? Where is your head at with all this information?
So with the physical exam, first of all, because the patient doesn't have any lymphadenopathy, and we are also concerned for malignancy in this patient, especially like different types of lymphomas. The fact that this patient doesn't have lymphadenopathy is kind of reassuring to me. Of course, we can't rule out only because of that, but this is a sign that we may not be dealing with malignancy. We also know that this patient has wheezing and crackles. So the things that I'm thinking about is the first one is, again, are we dealing with a flare of the PNK vasculitis, or this may be an infection, a regular pneumonia, or even like a pneumonia due to different pathogens, because this patient is in a state of immunosuppression. So these are the things that I'm thinking about with the pulmonary exam. And about the neuro exam, the decrease in sensation is very, very specific, and it seems like it's in a very specific nerve, if I'm not wrong. So it happens in multiple sites, but it's very, very specific. I don't know exactly how to make progress out of this, but I'm thinking if there is like an inflammation in the nerve in these different nerves.
Outstanding. I'm right there with you. I think we have minimized the degree of joint involvement, even though her ankles and feet are ankles and wrists are tender. The fact that there's no swelling reduces the yield of studying that information. And instead, what we have is a febrile a neurological condition, and localizing the neurological condition. Yeah, you're right. The lack of motor weakness argues against a muscle problem. And the lack of hyperreflexia, urinary symptoms argues against a cord problem. And the location and the distribution is very much suggestive of a nerve issue. And I think the question is, what kind of nerve issue? And nerve issues come in several different flavors. The most common is a slowly progressive symmetric polyneuropathy, which this is not. The other two interesting flavors are a demyelinating polyneuropathy, like that you would see in patients with B12 deficiency. And the spared proprioception and the spared reflexes are an argument against that. And so the least common kind of neuropathy is what's called mononeuritis multiplex, where individual nerves of the left thumb, as an example, may be affected. So I think this goes to say that I think you're right that the lesion is in the peripheral nervous system and in the nerves, most likely. And in cases where you're not dealing with this classic slowly progressive symmetric polyneuropathy, the major action step is to try to get an EMG to help you say, is this demyelinating or is this mononeuritis, mononeuropathy multiplex? And I'm very, very inclined to do that in this case to help us make progress. It's also interesting to see like what the pulmonary findings represent. Do they represent a site of a clue, or do they represent the scars from her previous activity in the lungs? And so I think the problem that we're going to try to solve now is an inflammatory disease featuring a neuropathy, prioritizing mononeuropathy multiplex. But I think because the fever is there, it's going to be important to get a sense of what the systemic signature of this disease is. So we know the lungs may be involved. The question is the liver involved? Is the hematological system involved? Is the kidney involved? So I think once we have the labs, we'll be able to try to make more concrete progress going forward. But I'm right there with you. The issue really is less arthritic and more neuropathic. And we can reflect a little bit more than we are now when we have that first round of systemic labs. All right, Jeffrey, Mike, to you.
All right, awesome, awesome. I love all these analyses. So the next aliquot is going to be the initial labs that she got. So this is 72 hours before there'll be another aliquot for 72 hours after. So her initial labs when she came to the hospital, so she was admitted for an AKI and fever. So CBC was notable for a white blood count of 15. Hemoglobin in hematocrit was 9.4 and 28, which is at her baseline. Platelets were slightly elevated at 513. The diff on the white blood cell count was 88% neutrophils. Her BMP showed sodium of 132, potassium of 4.8, chloride of 105, bicarb was low at 19, BUN was elevated at 48, and creatinine was elevated at 2.8 from her baseline of 1.1 to 1.2. Albumin was low at 2.6. Protein was elevated at 8.4. Glucose was normal at 104. Her other labs, liver function tests, notable for AST slightly elevated at 76, ALT slightly elevated at 48, where the normals are below 40 for both, and then an alk phos of 220, which was normal. ESR was checked and was elevated to 84. CRP was elevated to 8 mg per deciliter, so the cutoff for that is 1 on that scale. And her CK was normal at 38. As part of the initial lab, so these were all actually done in clinic when she got directly admitted. So I'll include the other part, which is actually she got repeat ANCA testing, which shows a positive p-ANCA at 1 to 1280, so very positive, and then positive MPO. And then finally, to round it out, her urine tests show a urinalysis that's positive for 2+ proteinuria, 1+ hematuria on dipstick, although she reports she's currently on her period, and a urine protein creatinine ratio that was calculated to 1.6 grams per gram. And that's that aliquot.
Oh my gosh, Jeffrey, very intriguing. Whew. All right, Mariana, we have our labs. What do you think?
I think the labs show us that we are dealing with an inflammation, especially with the high ESR, high CRP. As we were talking before, we have to assess if this patient, if the liver is part of the process here. I'm not sure, even though like the liver enzymes are elevated, I'm not sure if it's relevant for the whole picture here. Not sure if I would be very concerned with the liver at this point. And also the urinalysis with proteinuria. This is also shows that we may be dealing with a flare of the ANCA vasculitis. So this is what I'm thinking right now, but I think it's too early to not investigate other causes or like potential different issues with this patient.
Outstanding. Yeah, I think that's exactly where I'm at, is we're getting a lot of momentum towards ANCA vasculitis with mononeuritis multiplex is a working hypothesis, a very compatible consequence of vasculitis, proteinuria, plus minus hematuria given she's on her period, and the lack of other clues. So one interesting thing is the relative sparing of the liver in ANCA vasculitis. So if her liver were extremely elevated, even though we noted a little bit of an alk phos, that would be a counter argument. But I think what's interesting thing, Mariana, is let's reflect on something together, okay? Let's remove both your mind and my mind from this case to make a general reflection. If I tell you your patient has neutrophilia and don't tell you anything else, but ask you, what do you think the time course of their presentation is? What would you guess? Acute, subacute, or chronic for neutrophilia?
I would say it's acute.
Exactly right. Neutrophilia is really the marker of often acute bacterial infections, and we use that to our tremendous advantage. So you can make a lot of juice out of the fact that when neutrophilia presents subacutely, it actually tends to be unusual. And subacute neutrophilia has a very helpful differential diagnosis. So this is a stretch assignment for you and I, but where does subacute here, weeks plus neutrophilia, where does that take you?
So when I think about neutrophilia, I usually without considering if it's acute or subacute or chronic, I would say the main things that I think of when I see neutrophilia is infection and ischemia.
Yeah.
So if I think about um, if I associate acute neutrophilia to infection, I would say that subacute neutrophilia should be associated with ischemia.
Yeah, I think that it's interesting what you did there is you're like, I know it would be unusual for the kinds of infections that you think about with neutrophilia to present subacutely, and so you move to the other category, ischemia. What's really interesting about the world of infections is, yeah, a virus doesn't cause neutrophilia, acute or subacute. But the characteristic feature of infections that cause subacute neutrophilia are infections that hide. So the most common cause in all comers of an infection plus subacute neutrophilia is a large abscess. So a patient, for example, with a liver abscess presents classically with subacute neutrophilia. But the most common organisms that hide microscopically are those that hide not in big pockets of pus that a radiologist can see, but rather inside macrophages in the form of granulomatous infections. So as an example, subacute neutrophilia is a big tip-off to the possibility of tuberculosis and endemic mycoses. And so if we are to think, okay, subacute neutrophilia, maybe not virus, maybe not pyogenic bacterial infection, but TB, hey, very much so. Subacute neutrophilia in the world of cancer is very much compatible with a solid tumor. And so you might ask yourself, hey, could this patient, if they had an extensive smoking history, have lung cancer, or if they were having post-menopausal bleeding, which is not applicable here, could they have endometrial cancer? But what's really interesting, Mariana, is that the causes of subacute neutrophilia in the realm of autoimmune disease is also very small and few. You won't see subacute neutrophilia in lupus, you won't see it in Sjogren's, you won't see it in scleroderma. In fact, you won't see it in any ANA positive disease. Subacute neutrophilia is characteristic of vasculitis, especially ANCA vasculitis, and of two diseases that start with S, sarcoid and Still's disease. So, does this patient have Still's disease? Very unlikely. Nothing here is very evocative of Still's disease, no rash in particular. But I would say the hematological fingerprint is very compatible with an ANCA-associated vasculitis. It's not so compatible with a liquid tumor, except Hodgkin's lymphoma. It is compatible with a solid tumor, though a little bit less likely. So for me, I think you're right that we have to be careful not to call this just a flare of ANCA vasculitis and ask ourselves, could the patient be hiding an infection in a macrophage somewhere? And that's where I think knowing that she's from Mexico is really important, because do her lung findings represent tuberculosis, which has been camouflaged by rituximab? And more importantly, the most, well, I should actually ask you this because you may have been exposed to it. If I tell you the following buzzwords: subacute granulomatous infection of the peripheral nerves, very common in Brazil, often has nerve thickening, what would you think of?
Leprosy.
Exactly. So for me, I think this case is very suggestive of ANCA vasculitis. However, the greatest mimickers are granulomatous infections, and the neuropathic nature of this disease would have us wonder about leprosy, and the pulmonary focus of this disease would have us wonder about tuberculosis. So I think we have to hold those things closely to our chests before we assume it's just ANCA vasculitis. And unfortunately, if her kidney worsens, we might have to treat ANCA vasculitis, but that doesn't stop us from in parallel pursuing TB and leprosy. So I think the biggest learning, Mariana, is now you have exposure to subacute neutrophilia, and instead of eliminating infections, add to your list infections that hide either in big pockets of pus or in the macrophages. And I think that's the leap of knowledge that will help us take care of this patient together. All right, Jeffrey, you said 72 hours. All right, let's fast forward. Mike, to
All
you.
right. Yeah, so when by the time that I meet her is 72 hours within her hospitalization. So some of her lab changes, but also she's already gotten a lot of workup done by the internal medicine team. So we're gonna start with that. She's got a lot of infections tested for negative blood, urine, and sputum cultures. They tried to get to lumbar puncture, but she was unable to tolerate it, so they weren't able to perform at bedside. They got an echo, and that showed no evidence of vegetations. And then she also got testing for HIV, syphilis, gonorrhea, chlamydia through swabs, urinary swabs, hepatitis B and C, quant TB gold, and histoplasmosis. And all of those tests came back negative. The other workup, sorry, that she got was she got some rheumatologic testing as well repeated. So she has a positive ANA from 1 to 160, but otherwise her antibody profile is negative, including double-stranded DNA, Smith, RNP, SSA, SSB, and SCL70, as well as having normal levels of the complement factors C3 and C4. Additionally, she got some other testing for her neuropathy, and it showed a vitamin B12 level of 247. The normal is above 200, but in this range, it is still regarded as slightly low. Methylmalonic acid and homocysteine was checked, which was within normal limits. And then an intrinsic factor antibody had already came back highly positive at 13. And then while this workup was ongoing, by the time we see her, which is now 72 hours later, she's been receiving antibiotics for a couple of days, just empirically for possible community-acquired pneumonia. She reports when we see her that her fever and pain has completely resolved. And the only numbness and tingling that's still persistent is on her hands and feet. They had stopped her NSAIDs at the beginning, and the major lab change that we're seeing here is that the creatinine actually went down from 2.8 to 1.9 by the time we meet her, and that is aliquot 5.
Wow, very interesting. What are you thinking, Mariana?
So I have a lot of things to ask you about actually. So the first thing, we have a positive antibody for intrinsic factor, and also a borderline low vitamin B12. So I'm thinking, does this patient has pernicious anemia, and because of that has a low B12 that could have contributed to the neuropathy and the numbness and tingling that this patient was feeling. However, I don't think it would get better without without giving this patient vitamin B12. So I don't think that's the case. Another thing that is very interesting is that this patient was treated for presumed community-acquired pneumonia, and then both fever and pain resolved. So it's difficult for me to associate like the pain that the patient had with uh, just a CAP. I'm not sure if there's any gap in my knowledge that could explain that. Um, and another thing that I have to say is that maybe the creatinine that was elevated was just because the NSA that this patient was using. So we may not have like a kidney involvement at this time.
I think I have nothing to add to your excellent reflections. I think Jeffrey's presenting to us what it feels like in real life. And I would, I would summarize the following aliquot as, wow, great news, Ultimately, why are we all here? We're here to help this patient get better. And her fever is gone, her pain is gone, her neuropathy is still there, but her kidney function is improved. So that's it, right? Hopefully she'll keep getting better. And I hope that's the case. Just yesterday, though, we were discussing in the rapid fire session about the perils of subacute disease. So when somebody has a subacute problem, it's very often that they spontaneously oscillate. Things get a little bit better and worse, a little bit better than worse, a little bit better and worse. And so for me, the key question is, how long will she have improvement? Will she remain fever-free? Will her pain remain gone? And will her creatinine remain improved? And I think that's the key question. If she continues on a very gentle pathway towards improvement, then we would likely accept a very unusual diagnosis of community-acquired pneumonia and B12 deficiency with a normal MMA without treatment as her diagnosis. But I think everybody in the room should acknowledge that this would be an unusual combination and not something that a judge in the court of law would say is a really strong case. So shall we say the CAP and the B12 deficiency are guilty for a life sentence for this problem? I think it would be very circumspect. But if all we have done is treat them or diagnose them and the patient gets better, you can't make a counter argument. So I think now is the time to say, let's see how she is. And if she keeps getting better, great. But let's not pretend that we have sealed the deal. And time will tell. So maybe Jeffrey has another 72-hour story for us that things turn worse, or maybe she keeps getting better. Who knows? But that's all I would say. All right, Mike, to you, Jeffrey.
All right, amazing. So everything looked like it was getting better. I'm going to finish out with this last aliquot. So a couple of imaging studies come back. So she finally got around to getting ankle and wrist x-rays, and they were not suggestive of any type of inflammatory arthropathy. But they did notice there was some soft tissue swelling around the bilateral ankles at the hind foot, which was nonspecific, nothing on the wrist hand x-rays. She got a nerve conduction study EMG done of the left lower and right upper extremity, and it was consistent with the early motor predominant asymmetric distal axonal polyneuropathy. And so at this time, since the patient had been getting much better, she was given a diagnosis of possible community-acquired pneumonia flaring ANCA vasculitis causing synovitis and vitamin B12 deficiency, and was going to get discharged from the hospital. And right around the time of discharge, her fever came back to 100.5, and they checked a creatinine later that day, and it went from 1.9 to 2.5. Her new neurological exam at this time shows 4 out of 5 bilateral symmetric weakness in ankle plantar flexion and dorsiflexion, but is otherwise unchanged from a neurological exam standpoint. And she has new complaints that the pain and numbness and tingling are getting worse. And that is the final aliquot before I reveal the diagnosis.
And Jeffrey, just one question for you. Do you have to leave in 7 minutes, or do you have an extra 5 minutes afterwards?
Yeah, I have some extra time after.
Okay, I think this is so rich. It would be a shame, Mariana, not to do some form of breakout rooms just for 2 minutes or 3 minutes. So Feel free to dive in there, Mariana, with everybody else, so you can kind of share your thoughts and have people talking, because this case is too rich not to get everybody's thoughts. So I'll just literally do a 3-minute breakout room, and we'll come back and we'll intermix everybody's thoughts. All right, see you all soon. All right, back everybody. I hope you had all your thoughts intermixed together. And Mariana, where is your head at now? What insight did you gain?
So I think you are totally right. There is a subacute condition that is causing this patient to be better and worse and better and worse, and we have to find out what is that. So I'm trying to make progress with the information that we have. I'm not sure what the result of the EMG means. I'm not sure like what are the conditions that could appear with this type of uh, distal axonal polyneuropathy. So I'm keeping this in mind because it may be a clue of what we are dealing with. But the main things that I'm thinking are we know that a patient with an autoimmune condition may have like increased chances to have another one. So I'm thinking, is this just a flare of the ANCA vasculitis, or do we have to try uh, to diagnose another autoimmune condition associated with that? I'm not sure about infection. I would say that is less likely in this picture, but I'm not sure.
Yeah, I'm right there with you. I tried to pull up a schema to try to organize our thoughts. So I will just share that real quick. I think inflammatory disease involving the peripheral nervous system is very rare. You're seeing that there's a very small number of conditions. The most common is an autoimmune disease, especially a vasculitis, which is one of your leading thoughts here. You can see that cancers can do it too, and then infections. And for me, if I were to crystallize the two leading considerations here, is it that the patient has ANCA vasculitis causing infiltration of the nerves? And I think even if she didn't have a history of ANCA vasculitis, if you saw a patient who has a cryptic inflammatory neuropathy with AKI, you should think about ANCA vasculitis. And the fact that she has that history further reinforces that. And I think the possibility of leprosy is really only introduced based on her epidemiological profile. So if she was not born in a location in the world where leprosy were a consideration, I think there would be no alternative diagnosis that I can think of, in which case the diagnosis of an ANCA vasculitis flare would be very strong. I think this is a rare situation where you could make the argument for the most definitive test, which is a nerve biopsy, to either see hallmarks of vasculitis or to see hallmarks of granulomatous inflammation. But you might also say, well, that's a morbid procedure. This patient does not have any cutaneous markers of leprosy, any skin lesions, which is characteristic for most, but not all leprosy. If you are hoping to read about it, if you just research neuritic leprosy, you'll see that the disease can sometimes be just in the nerves. So the absence of skin lesions and the presence of kidney involvement leans more towards ANCA vasculitis, but there are cases where leprosy disseminates everywhere, including in the kidneys as well. So I think the no miss diagnosis here is lepromatous, diffuse neuritic lepromatous leprosy, but that is a diagnosis that is improbable. It's more likely that this patient with ANCA vasculitis is experiencing a very cryptic vasculitis flare. And I think it's very much a judgment call about whether to immunosuppress her and see what happens, or to do a nerve biopsy. But I think those would be my thoughts, more so ANCA vasculitis than leprosy, but I think it's hard to know 100% sure. But anyway, we're at the hour, so let's learn from Jeffrey and how he solved this dilemma.
Amazing. Yeah, I love to hear your guys' thoughts. I enjoyed hearing it in the breakout rooms as well. So you guys are completely right. The final diagnosis here is ANCA vasculitis. This was just a flare of ANCA vasculitis. And so, I have a couple of teaching points because I originally missed this diagnosis. So when the patient came in, they presented with a febrile illness with acute onset of what I thought was a symmetric sensory distal predominant polyneuropathy, just as Mariana mentioned. So actually, if you look at the clinical problem solver schema, I actually used this while I was on. The differential for that is limited to a couple of rare things. Acute intermittent porphyria and toxins are on there. The most common thing is Guillain-Barré, which I was trying to figure out, could this be like a rare variant of that? It was weird that she had reflexes. So initially, because everything was getting better, it seemed like maybe this wasn't a vasculitis flare. But once the nerve conduction study came back, and it shows a motor predominant axonal polyneuropathy is very rare, very rare for things to cause that. Other than, in my experience, vasculitis, you can have in rare cases other types of immune mediated types of conditions, maybe associated with like lymphoma or like myeloma. But when I saw that, my immediate response was that I had reflected on the neuropathy incorrectly. And this was actually just a vasculitic neuropathy. Um, when neurology interpreted the test, because of this weird vitamin B12 phenomenon, it was a little bit confusing. So they wondered, could it be from vitamin B12 deficiency? But again, the rest of this patient's course it can't be explained by just that. And for a vitamin B12 to cause an acute motor predominant polyneuropathy, it would have to be a very rare incident. Usually nitrous oxide poisoning is what I found in the literature for it to be this acute. So the only test we had that came back was we asked renal to spin the urine, and they saw red cell casts, which confirmed the diagnosis that this was ANCA vasculitis all along. And a lot of the issues initially were this confusing neuropathy and also the fact that she was on NSAIDs, which both helped some of her, probably what she had, inflammatory arthritis, but also led to this kind of AKI question. And um, and that was another confusing point in this case. But eventually, when we saw that she had red cell casts, the whole picture made a lot of sense. Fever, an axonal polyneuropathy, because motor predominant. And the reason vasculitis causes that is because the vessels supply the axon, not the myelin. And they supply actually for ANCA vasculitis specifically, not the small muscles, but the larger muscles. And that's why it leads to myopathy kind of complaints with weakness often. So in the end, this whole diagnosis ended up being ANCA vasculitis. So thank you so much for letting me share this case.
Jeffrey, I couldn't admire you anymore because not only are you teaching us like really high level rheumatological things, you're also showing us that experts also struggle. And I think for many of us, we're in the situation where we have so much inherent admiration for you all that we think your lives are very easy because you're so freaking smart, you know everything. And so all these diagnoses are effortless for you. And for you to be vulnerable with us and share with us the struggles that you had diagnosing this case is incredible. And for you to ultimately show us how diagnosing a flare of an autoimmune disease, which on paper looks so simple, there's a patient with autoimmune disease who's worse, is so complicated and so fraught and so difficult. So I really, really appreciate you. Yeah, I really, really enjoyed this hour. Mariana, I'm curious what your reflections are.
It was such an outstanding case. Thank you very much, Jeffrey, for bringing this case to us. And I love like the journey of us like thinking if this could be just a flare or if there was something else. And I think this is a very good stretch. For my start of internal medicine residency, I couldn't be happier. Thank you very much.
Mariana, you can't seem to avoid the neurology, but at least this time it was with a lot of internal medicine. So that made it for you and me. Jeffrey, any wisdom, any things that you want to re-emphasize before we hand the mic to Vinny to take us through the teaching point?
Yeah, I think the one thing that I learned a lot from this case is that you can have, oftentimes when you get taught about clinical reasoning, you try to do this Occam's razor thing where you have, one unifying diagnosis. And sometimes in the case, you have multiple different things that come up on your workup that can kind of explain the symptom. But I think a great learning point here was that unless it really, when you think about it thoroughly, does explain all the different processes, it's also important to keep an open mind to do further investigations, essentially.
So well said. Well, thank you so much for your time and your expertise. Really, really appreciate it. All right, Vinny, mic to you, my friend.
Yeah, so amazing session. Regards our learning points, we had a case of a 42-year-old female with a past medical history of ANCA-associated vasculitis. It was proved by renal biopsy and diffuse alveolar hemorrhage 2 years ago. That presented with symptoms of mononeuritis and multiplex at first glance and fever for 3 weeks. And she had like fever and wheezing in physical examination and arthralgias, and as I said, symptoms of mononeuritis multiplex. Labs revealed it to have an AKI with intrinsic factor antibodies that was highly positive. She was initially treated with antibiotics. After a couple of days, and the fever was back right before she being discharged of the hospital. And the AMG exam revealed distal axonal polyneuropathy and red blood cell casts were present, and all the clinical picture was compatible with an AAV flare. And the discussion initiated with the suspicion of the definition and a broad comment of vasculitis and how to differentiate between that. And the first thing that we should do is try to see if this episode is a complication, such as a flare or a new onset disease that can mimic the flare. And for that, we should consider autoimmune etiologies, and also the patient was taken rituximab and had a sustained remission with the immunosuppression, so that plays an important role here also. Other than that, the HPI is questionable regards the validity of the diagnosis, but afterwards, it became clear for us that it was a proof diagnosis. And then we expanded our discussion regards environmental exposures and vitamin deficiencies, lead poisoning, paraneoplastic diseases. And we also understood better the clinical scenario between the unilateral versus bilateral symptoms of the neuropathy, and being the bilateral symptoms are more concernable for a systemic etiology. And then all of this clinical picture points to a high suspicion of flare. But then the patient was treated for the community-acquired pneumonia, and the symptoms persisted, which induced us to investigate about differential diagnosis. And regards the infection bucket, the most prominent would be the leprosy, because the diffuse leprosy can affect a lot of organs such as the kidney, the skin, the nerves, the vessels. And but due to and also the patient had it's from a country that is from Latin America and has a more predisposability of this kind of disease. But due to that played a confounding factor in the case, and then we can see that the patient has a high predisposability for a AV flare, and the diagnosis could be made with the EMG and the red blood cell gas in the investigation. So that's all. Thank you.
Not an easy case to recap, my friend. You did a wonderful job. It's really, really nice to hear your voice back on Teaching Points. I know it probably felt really intimidating to have to recap all that, but I think you did a really, really good job. Thanks again, Lyra, for scribing, Mariana for a great discussion, and Jeffrey, huge, huge shout out. Hope to connect with you in the future. Thank you all. Have a great day, okay? Bye.